Good morning to all of you. Welcome all of you to the special Acoin session in AIOC Mumbai 2022. So at the very beginning, Dr. Gupta, our new member, is here. Dr. Karandeep Kaur is here. No. We'd like to welcome and felicitate the very young member who enrolled in Acoin Mumbai yesterday, but she is yet to come. That's why we will go to our session, and I would like to request Dr. Shatangshu Mathur, Chairman Scientific Committee of Association of Community Ophthalmologists of India National Committee, to deliver the welcome address. And at the same time, I will request Colonel Deshpande sir, Dr. Tariq Qureshi, our President, Dr. Praveen Basist, should get ready to give their address, very brief address in this preamble part of this introductory part of this particular session. Dr. Shatangshu Mathur, please.
Thank you, Dada. So we welcome you all in this early morning in the Acoin session in Mumbai. So we welcome our special delegate from Bangladesh, my sister, Dr. Himanti Chaudhary, our incoming president, Dr. Palsy sir, and all of Dr. Phobias and all of you, Dr. Manoj Mathur from Hyderabad. So we start our session. Before we go to the session, we can have discussion later on. So I invite Professor Suraj is not here, Dr. Vachist? He is not here.
We have got some preamble. Professor Deshpande sir is there?
No, he is not here.
No.
You can see, no, sir.
So, I just like to tell you something about very couple of lines on the outline of this particular session. This particular session is a pan-India picture of community eye health practice, the ongoing situation in Indian subcontinent. We have got the pleasure to have the speakers not only from different parts of India but also from Bangladesh. And each one of you have got so many beautiful experience and so many materials to present. But unfortunately this time we got only around 85 minutes. And other years we like to enjoy around 4 hours with so many speakers and others. That's why the time is very limited. And we have around 20 speakers within this short time. So I would like to request each one of you to make use of the double podium alternately and to keep your presentation only within 3 to 4 minutes with title only. And those who like to have some elaborate discussion can have a talk with you during the leisure hours or can communicate with you over WhatsApp and on other mail, on other social medias. With these few lines of the outline of this particular session, I like to request Dr. Praveen Basist to give the core concept of this community eye health practice in India. Very briefly, core concept, because he is the chief of the National Program for Control of Blindness of Government of India. He can give what is the government's idea of catering community eye health care service in India.
No presentation. Thank you, sir. I welcome all of you in this session. In fact, as far as community ophthalmology is concerned, I have observed that most of the doctors, ophthalmologists, they feel that if they are conducting camps, that is something community ophthalmology. But I believe the community ophthalmology is much more beyond this thing. What we look forward from national program point of view, that we need to strengthen, the first and foremost thing is we need to strengthen our primary eye care system. I'm very sorry to inform you that India is considered among those countries which have worse primary health care system. This is the current status. And as an Aconian, if we can improve our primary eye care, and that is their two concept, at the primary level, at the community level, we can, in fact, I'm expecting everyone that we can train ASHA workers and health workers in primary eye care. That is the core concept. We have 1 million ASHA worker. And as collectively, if we can train them in screening of diseases, that can be a big initiative. There is no need for a doctor ophthalmologist to go to community and conduct such camps. Second level is the vision center level, which Government of India right now promoting each and every institute second level institute, they should have vision centers. I request all of you to please have vision centers in our area. And beside this, we promote that more and more data should be developed. In fact, now our vision is that each and every district in country, they should have data related to blindness, data related to visual impairment and causes like RAB survey or RAVI survey should be conducted. And for that, if any of the member is interested, RP Center will be very happy to train their teams and also to help in them in analysis and report writing also. I think I should not speak much.
Thank you, Dr. Vashish. And really, Vision Center concept is very good. We will like to have your views on this if we have time here after this. So we have, Dr. Rohan is not here, so we are starting from Dr. Manoj Mathur. He is a very renowned ophthalmologist from Hyderabad, and we have been associated with our association for a long time. So Dr. Manoj Mathur, sir. Next ke liye ready rahiye. Next either. We request your next speaker should get ready on the next podium so we can have more time for discussion.
I would like to request once again Dr. B.N. Gupta is already here on the chair. If anything more on this chair, Dr. Indar Mohan Rustogi is here.
No.
Das Mukherjee, no. Okay. Chalo. Yes.
आपका अपलोड किया
बोल तो देना बाद में
तो ठीक है.
Yes. So Dr. Manoj Mathur, he has some problems. So we started with the Dr. Saroj Gupta. चालू है वो?
चालू है.
मैडम सरोज एक मिनट रुकिए. तो देर क्यों लग रही है? टाइम नहीं है ना हम पे.
एक मिनट स्विच करके आता हूँ. Yes, Dr. Manoj Mathur will start. Okay.
Thank you, Acoin, for giving me this opportunity to speak on my topic about need to shift the model for opportunistic screening in our community. Glaucoma is referred to as a sneak thief of sight and is often detected late due to lack of awareness. Approximately about 90% of the patients with glaucoma in India remain undiagnosed, and conversely, about 50% of the patients on glaucoma treatment are non-glaucomatous. There lies the need to increase awareness and about glaucoma so as to reduce the burdens of undiagnosis of 90% to about 50% as in developed countries, as well as organize CME programs for ophthalmologists as to correctly treat the glaucoma and now reduce the burden of overdiagnosis of about 50%. Glaucoma, being a multifactorial disease, cannot be screened by a single test. The normal statistical intraocular pressure ranges between 12 to 22 millimeters. Hence, the need to shift from pattern of screening from community screening model to opportunistic screening model. What is this opportunistic screening model? I'm taking the reference of my state, Telangana state. We have 30 districts in Telangana. We need to establish 5 vision centers in each of the 30 districts manned by an optometrist or a vision care person. These vision centers should then be equipped with a slit lamp and non-myopic camera that is being already planned for diabetic retinopathy screening. What I am suggesting is by just adding an applanation tonometer to this proposed slit lamp, we can also give emphasis to glaucoma detection on a perpetual basis. So what should be the model? As the previous speaker said, the need for involvement of Ashawa, the Anganwadi workers at the rural community level. Then the role of the vision centers, and after the vision centers, the ophthalmologist exam at the district level hospital for field assessment, gonioscopy and management, and then if required, the tertiary care. So what a rural Anganwadi worker can do is follow a questionnaire, history of blindness in the family, ocular injuries, diabetes, hypertension, thyroid disorders, long-term steroid medications. You can have a small questionnaire for the Anganwadi worker as to pick up patients to be referred to a vision center. What an optometrist can do in a vision center is doing a Van Herrick test on slit lamp, look out for iris atrophy, measure intraocular pressure, and then document optic disc photograph. That can be done in the vision center. And this opportunistic case detection, the rate goes up exponentially. This is the Van Herrick test, this is the iris atrophy slit lamp, the applanation tonometry that can be done at the vision center, and photography, optic disc photography. And based on the findings of the training the optometrist, selected patients can be sent to the district hospital, where an ophthalmologist examination can be done by an ophthalmologist, and by measuring again, rechecking the IOP, gonioscopy, optic disc evaluation, field assessment and management, whether medical or surgical. All these tests can be done at the district hospitals. Then at the specialist exam at the tertiary hospital, further evaluation if required by way of CCT and OCT and management with medical or surgical lasers can be done. So, to conclude, an ideal model for perpetual glaucoma screening for glaucoma is to shift the pattern of screening from the community screening model to opportunistic screening model by utilizing the existing infrastructure. What I mean to say is, I always tell Dr. Subudhi, like you are in the forefront about diabetic retinopathy. So by just adding an applanation tonometer to your slit lamp, the glaucoma opportunistic screening can also be done. Thank you.
Thank you, Dr. Manoj Mathur. It's a very good idea. You have already, previously also you had suggested it. So now I invite Dr. Rohan Chariwala.
She's yes. Dr. Saroj, you are here. You
By the
start.
time you prepare, Dr. Saroj Gupta, you please.
Yes.
Please
And we request all of them you to restrict for the timing allotted, because we have many speakers and we need discussion time also. रोहन इसके बाद आ जाएगा.
So, very, hello.
आप यहाँ सुनिए कम, ये देखिए.
Hello. Hello. Is it working? Okay. So, very good morning to all of you. And thanks to Acoin for
Dr.
giving me
Madharia, please join
opportunity.
us on the stage.
Nepaliya bhai.
So, correct diagnosis of glaucoma and its management is a challenge, because glaucoma is an asymptomatic disease, or often it is missed, or patient presents very late when they have lost the vision in the one eye. And as Dr. Mathur said, about 50% of subjects in developed countries even do not know that they are suffering from glaucoma. And in India, about 90% patients are not aware that they are suffering from the disease. And 50% of patients, those who are on medication, they don't need medication because mostly they are overdiagnosed. So these figures indicate that under an overdiagnosis of glaucoma is quite common. It has a serious consequences. So I'll be sharing one or two cases, like a 32-year-old male who presented for refraction, gives history of using anti-glaucoma drugs since 1 year in the right eye, and his fundus examination showed asymmetry of the CD ratio of more than 0.2, and his IOP was normal, but the discs were normal because the rim was normal. There was no notch, no thinning of the retina, no hemorrhage, no signs were there except for the asymmetry of the cup was there. And the other investigation, when we investigated, all were normal, the fields were normal, the OCT normal, and the disc was absolutely normal. His asymmetry was because the disc size were asymmetrical. So asymmetric disc is important, cup is important when the discs are symmetrical in size. So only on the basis of this suspicious disc, the patient was diagnosed with glaucoma. So there is an overdiagnosed glaucoma, and patient was advised to use the anti-glaucoma drugs. So we stopped the drugs and we followed the patient. We found even after 3 years, the fields were normal and the discs were absolutely normal. So we stopped the drug. And thus, just on the basis of disc finding, which was suspicious, the AGM was started, thus the patient was overdiagnosed. So another case, a 37-year-old male who came with glare and decrease in vision in the right eye, and he was using glasses. He was visiting ophthalmologist many times. So his pupil was mid-dilated, there was loss of pupillary rough, IOP was high, so we thought could be case of trauma. So we took a history of trauma, and he gave a definite history of blunt trauma 12 years ago. So we recorded IOP was 28, so we did gonioscopy, which shows a recession of the angle in 3 quadrants, shows a advanced disc changes glaucomatous, and the field also shows a severely depressed field. So here the diagnosis was missed because the detailed ocular examination was not done in this case. So young patient, usually they are misdiagnosed, they are not diagnosed of glaucoma because detailed evaluation was not done. Another case, a 20-year-old young male who had complaints of itching and redness on and off since not 8 and 10 years, visiting ophthalmologist many times, prescribed drops, used over-the-counter drugs also, vision was 6.6. But when we thought, because he is on drops frequently since 10 years, could be a steroid, so we recorded IOP. To our surprise, it was 36 and 34. And the disc shows advanced cupping because he was on steroids. And a young patient, 21-year-old, such a advanced glaucoma optic atrophy with advanced field changes. Here again, the patient was misdiagnosed because the detailed history and the examination was not done. So we know the glaucoma is underdiagnosed because it's asymptomatic disease. So often patients do not present themselves, or they present very late. So it's important to make people aware of this disease, and even when they present for any other complaint, they are not fully, comprehensive examination is not done. Even Chennai glaucoma study has shown that 50% newly diagnosed glaucoma patient had an eye checkup in previous year. I mean, they visited ophthalmologist, but it was missed. Only 20%, less than 20% was diagnosed with glaucoma. And because of fear of blindness, glaucoma is often overdiagnosed. Like if IOP is more than 21, the anti-glaucoma drug is started. And even if the disc is suspicious, the anti-glaucoma drug is started without doing a comprehensive ocular examination. So implication of over underdiagnosis are very substantial. Underdiagnosed case at risk of losing the vision, and overdiagnosed case unnecessarily exposed to anti-glaucoma drugs. And all the side effects of drugs, the financial burden, the quality of life also suffers. And mostly the young patients which are not diagnosed, because we think glaucoma is a disease of old age people. So mostly they are old age are overdiagnosed and younger are usually underdiagnosed. So to conclude, we have to increase awareness about glaucoma in public. So they come for preventive checkup, they come for regular checkup, and when they come for any complaint, we have to do a comprehensive eye examination known as opportunistic screening for glaucoma. So basic slit lamp, IOP and dilated frontal examination should be done in all these patients so that we can suspect glaucoma. And we suspect, we can go for detailed evaluation like visual field, OCT, pachymetry, gonioscopy, so that we don't miss glaucoma. So if this strategy is adapted, then this problem can be solved. Thank you so much.
Thank you.
Soumendra Ghosh, next speaker.
Thank you, Dr. Saroj, for giving a very good tips for the glaucoma screening. Now, may I invite Dr. Rohan Chariwala?
Yeah,
are you ready?
Soumendra Ghosh.
So, Dr. Soumendra Ghosh?
They are ready.
Yes, sir.
First of all, good morning, everyone. I'd like to thank Acoin for giving me the opportunity to talk in front of you. Today I'll be talking on acute congestive glaucoma, what we are lacking in the basic comprehensive care in the era of pandemic. So I have no financial interest. This is a very small study to evaluate the understanding of acute congestive glaucoma by the primary care ophthalmologists during pandemic era. The study design was, this is a retrospective analysis of the last 2 years case of mine from 2020 and 2021, and all the patients of acute congestive glaucoma from the last 2 years were reviewed. Time and cause of referral, detail of the initial treatment and reason of failure of the initial treatment, if any, were particularly evaluated. We excluded phacomorphic and lens subluxation glaucoma from this study. And the result was a total of 133 new patients were diagnosed as a glaucoma, and among them 74 patients, that is 55.6%, were angle closure variety. Among them 16 patients, 21.6% were having acute congestive glaucoma. 21 eyes of 16 patients has ACG. That 8 patients, that is 50% of the patients, are initially consulted with the primary care ophthalmologist. Then they refer the patient or the patient came on their own. So these are the charts. We can see here the different aspects we examined in referral card, from the past ocular history to the past medical drug history, tonometry, slit lamp, gonioscopy, disc evaluation and fundus, and lastly diagnosis. So if you see this chart, only 2 patients, that is number 5 and 7 patient, has all these criteria fulfilled. And if you see the tonometry, 2 cases, first and 8 cases, does not have any kind of tonometry. And other has some kind of tonometry, maybe a COG or other kind of tonometry, NCT. Gonioscopy is done only 2 cases, although sometimes it's very difficult to see the angle structure during gonioscopy at this stage. But still, they 2 at least mentioned that gonioscopy was tried. Same about the disc evaluation and fundus, and diagnosis is written in all the cases except 1. So as a result, what we can see, the 2 cases were falsely diagnosed as iritis, and 1 patient has a previous PI which was closed, and that was the reason for an attack. And a case of bilateral simultaneous acute congestive glaucoma was missed because the patient does not have a drug history. It was a case of topiramate induced bilateral angle closure. And if you can see that I have done the UBM, and we can see here the angle closure, the anterior swelling of the ciliary body, and suprachoroidal effusion is there. And you know that patient who came late actually associated with the surgical intervention ultimately, and ultimately poorer outcome. So prevalence of the angle closure glaucoma in our country is around 0.23% to 0.88%. In hospital setting, half of our glaucoma patients are angle closure variety, and a large proportion of the PSEGs are acute congestive glaucoma. The detailed history taking and comprehensive eye examination are the key to the diagnosis of this ocular emergency. So this was a paper published. It has just concluded that implies that glaucoma was detected in 36% of the patient, only 36% of the patient who received the anti-glaucoma medication. However, LPI which was needed, or surgical type or laser, was done only in 8.3% of the refer patient. So the lower rate of LPI, either due to non-availability of the Nd:YAG laser or inability to recognize the condition of PSC or PSCG patient, is matter of concern. Another one by Dr. Ramanjit Siota, he just emphasis on acute PSEG eyes present late and frequently require a trabeculectomy to control IOP, but visual prognosis is generally poor. Chronic PSEG eyes appears to progress faster than the POAG. So in the conclusion, what in this small study indicate there is a considerable lack of understanding about this emergency by the primary care ophthalmologist, and it is mainly due to lack of comprehensive workup. Thank you.
Thank you, Dr. Somin. So
I'm ready.
now Dr. Rohan Chariwala is ready with his presentation. So please.
Yeah. Good morning, Chair. Good morning, everyone. Thank you, Acoin and Sapan Samanta sir, for giving me opportunity to speak on magnitude of blindness in India. As you all know, India is home to the world's largest number of blind people. The number of blind persons in India in 2000 was estimated to be 18.7 million. And it is projected to be 31.6 million in 2020. As per NPCB, the prevalence of blindness in India was 1.1% in 2001 survey and 1% in 2006 and 7. As far as causes of blindness are concerned, cataract remains the major cause, 62.6%. Refractive error stands second, roughly 20%. Glaucoma 5.8%, and corneal pathologies 0.9%, and other causes 11%. As you know, cataract is a major reason for blindness. The untreated cataract remains the major challenge for the country till now. It is still persisting as the major cause of blindness and visual impairment since the inception of the national program. Extrapolating the observation of various population-based surveys to entire country, it was estimated in 2001 that there were 7.75 million individuals whose blindness could be attributed to cataract, and this would increase to, as we saw, 31.6 in 2030. As far as corneal blindness is concerned, the major causes are corneal ulcers, trachoma, corneal dystrophy degeneration, and trauma. In India, it is estimated that approximately 6.8 million people have less than 660 vision due to corneal diseases. Various surveys suggested 8.2 to 9% of causes attributed to the corneal diseases. Corneal opacities have emerged as the second leading cause of blindness in 2015-19 survey also. As far as trachoma is concerned, trachoma was one of the leading cause of blindness in India, but still it is there in very few pockets in India. Government of India declared the elimination of active trachoma among children, but the prevalence of trachomatous trichias is still above the WHO elimination criteria, and the surveys are being planned to estimate the exact scenario of the trachoma. As far as childhood blindness is concerned, in India, 3,20,000 roughly, less than 16 years are blind due to childhood blindness. And as reported by Dandona et al., the prevalence of blindness was 0.17%, and this corresponds to about 6,80,000 children. Causes are corneal scars, vitamin A deficiency, cataract, trachoma, etc. Glaucoma, a leading cause of irreversible blindness. In India, around 12 million people suffer from glaucoma, and 1.5 million are blind due to it, so making it the third most common cause of blindness. As far as diabetic retinopathy is concerned, among 20 plus population, there were an estimated 65 million people with diabetes in 2016. Assuming 15 to 20% of these individuals have any diabetic retinopathy, and 5 to 7% have vision-threatening diabetic retinopathy, 3.25 to 4.55 million people are at risk of visual loss due to that cause. As far as uncorrected refractive errors are concerned, the prevalence was 10.2%, but heterogeneity in these estimates were very high. The glimpses of National Survey 2015 to 2019 are the blindness, the prevalence of blindness was like 0.36% in the overall population. Severe visual impairment stands at 0.35. If we make extrapolation according to that, so blindness numbers that total population is 47,99,274, and total visually impaired people are 3,40,06,000 something. Causes, as we all know, the preventable and treatable are in majority. Causes are in the same category. You can see the cause of blindness and visual impairment in 50 plus population. I am not going in details of it. As far as causes are concerned, cataract remains untreated. Cataract is 66.2%, and trachomatis and corneal opacity stands 0.8%, glaucoma 5.5%, diabetic retinopathy 1.2%, glaucoma 5.5%. I'm just skipping this slide because there is a repetition of the same. As far as diabetic retinopathy is concerned, prevalence is like that, like 16.9%, prevalence of macular is 7%, sight-threatening diabetic retinopathy is 3.6%, non-diabetics are 8%, and the message is there is overall reduction of visual impairment, but still we have challenges to conquer and miles to go to achieve these goals set by WHO through Universal Eye Health, released in World Report for Vision 2019. In order to achieve universal eye health coverage, there is a need for stronger integration of eye care within the healthcare delivery system at all levels, with specific emphasis on primary healthcare level. The eye care services should be people-centric and must be provided closer to communities. And by saying this, I am concluding my talk on magnitude of blindness. Thank you so much for patience hearing. Thank you.
Thank you, Dr. Rohan Chariwala, for giving a nice overview of the magnitude of the blindness problem. So before I move to the next speaker, may I request Dr. Nepalia to speak a few words?
I compliment you for a very comprehensive, presentation. As blindness is a very big multifactorial problem in our country, and we have Dr. Vashish with us, so I'll just request him to give a brief account as to what is Government of India is doing to overcome this big magnitude of blindness in our country.
Sir, at present, as Rohan has given details of the latest blindness survey, the prevalence of blindness is reduced significantly, but now entire emphasis on visual impairment. As he mentioned, there are nearly 3.5 crore people, 35 million people are visually impaired in our country, and the maximum emphasis at this stage is still on cataract, because 66% of blindness is due to cataract. Recently, in fact this month only, Prime Minister has launched a special program for cataract elimination in our country, cataract backlog elimination, and under this program we are targeting that in next 3 years we'll be conducting 2.7 crore surgeries, 27 million surgeries, and mainly targeting blind and visual impairment. And I believe the Prime Minister office was giving a significant amount of fund for this program also. This is the key initiative, but beside this, other diseases are also important. For trachoma, we have not yet declared trachoma elimination. The Government of India is doing TT survey with the partnership with WHO and Tropical Data, and RP Center is involved, and we are doing survey in 200 districts so that we can show to WHO that trachoma is not there in our country. Beside this, more and more emphasis is being on diabetic retinopathy and glaucoma. Corneal blindness is the second leading cause of blindness. So Government of India is giving emphasis in eye donation, starting eye banks, and developing keratoplasty surgeons. I think these are the key initiatives at present under Government of India. Thank you, sir.
Thank you, Dr. Praveen, for giving a nice overview of what the government is thinking and going to do. So Dr. Arun Sethi is, I think he's not there. So I will now invite Dr. Himanti Chaudhary to present your talk.
Thank you very much. Good morning, everybody. I'd like to thank Dr. Swapan Samanta, sir, for giving me this opportunity. I'll talk about Community Eye Care Service, South Assam experience. We have no financial disclosure in this presentation, and since the problem status has just been discussed, so I'll skip that. So keeping the problem status in mind, what as ophthalmologists we can do at our setup. So we have a team of ophthalmologists, optometrists, technician, counselor, attendant and cleaner. And after the COVID pandemic was relatively over, after a lull of 2 years, we again started doing our routine fortnightly camps. So in those camps, we don't just go and screen for cataract, we also give a public awareness talk, and those talks are mostly on relevant topics like diabetic retinopathy, on cataract and on glaucoma. Then we also screen for cataract, call them to our base hospital, do the surgery, and some of the extra things that we do there, we also give presbyopic glasses there, and for those who require distant vision correction, they are called to our vision center. We give proper media coverage before and after conducting the camps because we want maximum patients to be benefited for them, and also we want the patients to know about the activities that we are conducting so that they can take benefit of that in future. These are the post-cataract cases who come to our base hospital again for the post-operative checkup. As part of patient education campaign, as I already said, the talks in the camps, we also sometimes conduct local news channels. We give talk on glaucoma or on relevant topics. Sometimes this is a press conference. The below left photograph is a press conference that we conducted on the Glaucoma Week, and we have also given coverage of that in the AIOS web page about what are the activities that we will conduct over the week. During the month of November 2021, we had done the glaucoma diabetic retinopathy awareness camps. We did a retinopathy screening in our base hospital, and also awareness walk for glaucoma and as well as for diabetes. This is a virtual platform awareness campaign that we do. It was in association with the Rashtra Sevika Samiti, where I was given the responsibility of training young mothers on how to protect their children from COVID-19 and also how to protect their eyes during the pandemic, how not to do too much of visual terminal display screening. So these are the activities that we do. This is as part of our CME drive. We do monthly or bi-monthly CMEs and most of the ophthalmologists of our town and nearby district also come, and the postgraduate students of the medical colleges also come. Here you can see below, Dr. Varun Nayak sir had also had the opportunity. We had the opportunity of having him at our setup. So our statistics in the last 7 months are we have conducted 22 camps, number of patients screened at 2,983. Number of patients operated 266, and awareness talks, either physical or virtual, were given 16. Thank you very much for your patient hearing.
Thanks, Dr. Himanti. We have with us Professor Shaukat Ara Shakur from Bangladesh, and I welcome you, ma'am. She will be speaking on the National Blindness Report from Bangladesh.
I'd just like to introduce Professor Shaukat Ara Shakur from Bangladesh.
Onto the mic.
He doesn't need mic, you know.
Professor Shakur is now attached with National Institute of Ophthalmology, the apex institution on ophthalmology of Government of Bangladesh. And at the same time, she was the honorary secretary of Bangladesh Association of Community Ophthalmology Service. And she, as his post-graduation and postdoctoral from International Center for Eye Health, London. And she was one of the founder member of our Indian alumni group of the International Center for Eye Health, London in long back in 2000, and then she had already become the member of the Association of Community Ophthalmologists of India. She is one of the regular visitor and participant of all our Acoin activities here. So it's a great privilege to have Dr. Shaukat Ara Shakur, and we are all eager to hear from him about the scenario in Bangladesh right at this moment. Thank you, Dr. Shakur.
Thank you, Dada. A very good morning to you all. Very good morning to the panelists, and I start my presentation now. And it's my pleasure to be here in the DreamCon conference. It's not moving. हो रहा है तो नहीं हो रहा है. Okay, so I'll be talking about the blindness report. We have just concluded in 2013 the Prevalence of Blindness and Low Vision Survey, and it is published in British Medical Journal Open. So I am giving you a glimpse of the result of that survey. So this was the study which we did by National Institute of Ophthalmology and WHO, and the objective was to determine the prevalence of blindness and its determinants in Bangladeshi adult population. And it was a cross-sectional population-based survey conducted at household level with national representation. Samples were drawn from the 2011 national census frame using a multi-stratified cluster sampling method. The survey was done in the urban and rural areas in 2013 using a probability proportionate to size sampling approach to locate participants from 72 primary sampling units. One man or one woman aged more than 40 or 40 years was randomly selected from their households to recruit 7,200. We used Kish table for this. And this was some pictures of the survey, some pictures. And in addition to socio-demographic data, information on medication for hypertension, diabetes was obtained, blood pressure and capillary blood glucose were measured, eyelid, cornea, lens and retina were examined in addition to visual acuity and refraction testing. So this is because time is very short, I'm not going in details, this is the procedure we followed for data collection. So I'm going to the result. The response rate was 88.8% because 702,000 were our sample, and we could get people 6,384, and 53.8% of them were women. Men and women were similar in terms of age categories, and average age was 54.3 years with a standard deviation of 11.2 years. Half of them never attended formal school, and 1/5 had above primary school education. Women mainly were homemakers, but almost half of the men were manual workers. More than 6 in 10 were tobacco users. 1/5 were overweight, body mass index more than 25 per kg per meter square, and 5.4% had hypertension, blood pressure more than 140 per 90 millimeter of mercury or on medication, and 7.8% had diabetes mellitus. This is the result of the demographic and all the education, everything here. I'm not going in details in it. And overall, the age-adjusted prevalence of low vision and blindness was, for low vision it was 12.1% and blindness was 1%. In our last survey, which was conducted in 2000, the blindness was 1.53%. And it was conducted in population of 30 years or above, and our population of these samples age was 40 years and above. So age was a difference. Blindness was higher in those aged 55 years or older. It was 1.8% compared with the younger pupil, 0.2%. Those who are 55 years, less than 55 years old. An increasing trend of blindness prevalence across age groups. There was no differences were observed between sexes, and residential areas or urban, rural, there was not much difference, as indicated by the overlapping 95% confidence intervals. So here we can see the prevalence of blindness. In men it is 0.7%, in female it was 1%, and urban 0.5%, that is an important finding, and rural 1%. Because urban they get more facilities, more for, my time is up. I have 1 minute. Can I have 1 minute?
Yeah.
Okay.
Sure.
And this is the prevalence in 40 to 49 age group is 0.2, and it increases, and in 60 to 69 it is 1.3, and 70 years and above it is 4. So this is, and in our sample 22.9% had cataract of some form. It is in the whole sample. 22.9% had some form of cataract, 1.7% had diabetic retinopathy, 0.8% had glaucoma, 0.8% had corneal diseases, 0.5% had AMD, and 0.4% had eyelid disorder. So it is that glaucoma and diabetic retinopathy and ARMD is coming up with the, it was not in the last survey. So in conclusion, cataract is responsible for 80% of the preventable causes, And national blindness program, we have a national blindness program. It is mostly focused in tertiary centers. So it needs to be strengthened in primary and secondary care systems to reach out to most people who need the services. The creation of public awareness for seeking services could broaden to coverage of national eye care. So in this short time, it is not easy to present a blindness survey. I tried, and this is the survey. It is published in British Medical Journal Open, so you can get it there. Okay, thank you.
Thank you, Dr. Shakur. So you told that the last survey was conducted in 2013.
It is 2013, and
okay.
with that it is published last year.
So during these 10 years?
Not 10 years, 2013.
9 years.
It took a lot of time because we wanted our data to be, we checked it again and again, and we had some problem in one stage to publish it. You know, sometimes they want the data to be of their choice. It should be like reduced, but we didn't compromise.
You mean to say that the again survey has been conducted, but you are yet to publish it?
No, this is the one.
So this is the latest one.
The new one is 2019, and it is yet to be published.
Okay. Thanks. We have Dr. Praveen Vashisht with us. So I think I will like to request him to give your comments in reference to Indian scenario.
Ma'am, I just want to know one thing from you. What definition of blindness and low vision you have taken this? Low vision is 618. Less than 618. Yeah. In fact, the thing is that when we compare the National Blindness Survey of India and Bangladesh, though they have done in 40 plus population and our survey was in 50 plus population, but if I try to explore about this prevalence, it is almost similar. Bangladesh is slightly less, but it is not significant difference. The prevalence of blindness and visual impairment. Yeah. I'm extrapolating it to 40 plus also. We have done it for entire population also. So it is almost similar. In 50 plus, if getting around 2%, then it is 1% in 40 plus. This is an approximate association between these two. But in your case, you have shown 80% is cataract, the cause of blindness. That's too huge actually. 80% of blindness due to cataract is a big burden in Bangladesh. And that I can really estimate because in Bangladesh, the cataract surgical rate is believe around 1500 surgeries per million population per year. Where in India, it is more than 5,000 surgeries per million population per year. So Bangladesh has to work more for cataract compared to even India right now. Thank you, sir. Thank you.
This particular data is of debatable help. 9 years back.
Yeah, that's what I was just pointing out. Yes.
Interesting thing. 50% illiteracy in Bangladesh. That is not right now. I think.
Sir, it is in 40 plus population. So older the population, you may have literacy. Yeah, in our case also, I don't know the exact proportion right now, but as far as illiterate are concerned, the prevalence of blindness is much, much higher. It is 3.4% among illiterate compared to around less than 1% in literate population. Exact percentage, what is literacy, that I am not aware.
What about your cohort? How much illiteracy was there in your cohort?
So around 40%. 40%? In 50 plus age group. It is there. Because people, they say they have not studied. So that is assumed as illiteracy something. Right.
And what has been the impact of this COVID in the last 2 years on this program, Dr. Vashisht?
That's so important, impact of COVID on national program. I can say the number of surgeries we are performing in India, around 65 lakh surgeries per year. That has reduced to nearly 32 lakh surgeries per year. Less than 50%. This is for cataract. And if I talk about corneal blindness, that is further. Probably not even a single eye bank was performing keratoplasty surgery during this COVID period. So effect is really much, and probably we need a new survey at this stage to actually assess the impact of COVID in our country. And this is definitely much, much higher. Thank you.
Thank you, Dr. Vashisht. So now I invite Dr. Usha Chaudhary to please present your talk.
Hello. A very good morning to all of you. I I would thank Dr. Samantha and the Acoin managing committee to accommodate me at this last minute. So my speciality is that there is an area which is which is a niche, and being in the executive committee of the Indian Academy of Cerebral Palsy, I felt that this presentation was extremely important, and I would like to draw all your attention because this is a place under sunshine for all the special children. So being in the committee, we formed a committee 3 years back where I am heading this committee, and in coordination with LVP, we have, and the Spastic Society of Bangalore, we have a couple of doctors who worked with me, and our mission was save vision in developmental disabilities and create awareness. So let me run through, what a cerebral palsy means. It is, a problem of the brain which is not developed fully, and the cerebral palsy is one condition where the child goes to multiple specialists like orthopedics, ophthalmologists, gynecologists, dentists, psychiatrists, pediatricians, speech therapists, OT, PT people, and the most important is the society and the NGOs, the healthcare workers, the parents and the teachers. So it's not that we alone as ophthalmologists can work on this. It is a multi-speciality disciplinary, and we alone can do nothing about this. So the objective of our study was to detect firstly the ocular anomaly, record the visual capacity, whatever the capacity is there, treat the visual problems which are neglected by many of the medical and the paramedical and the non-medical members, and overcome this visual handicap in time and facilitate overall rehabilitation and development. So the visual issues in children, we all know that in the infant and children, the visual system is very dynamic and sensitive. So we classified it into reversible, partially reversible, where there was almost 100% correction by doing a regular checkup, giving the right glasses and treating them at the right time. But the most important was early detection. And the second category was irreversible, where the visual rehabilitation specialist played an important role. And I felt that if these children were examined and got to an eye specialist at an early stage, we could have done a lot for them, because at the end of the day, what these children need is being independent and move on with their life with whatever handicap they have. So the incidence of visual loss in cerebral palsy, way back, Peter Black, mentioned that in his literature mentioned that 80% of the children had cerebral eye problems in cerebral palsy, and 20 were normal. And in the study where we carried out, we found that 91% of the children had eye problems. Now, how can this be incidental? Is it possible for us to make a difference to the lives of these many children and families to maximize their visual potential? Yes, we can. Another interesting thing that we found when we carried out this study was the children with cerebral palsy did not have one eye problem, they had multiple eye problems. Now, Save Vision in Cerebral Palsy is our initiative of Indian Academy of Cerebral Palsy. We want to aim to reach out special educators, occupational therapists, workers at the district early intervention centers, provide training in use by projecting simple questionnaires to identify especially the cortical visual impairment, and using simple methods where ophthalmologists may not play a very important role. But if these people, the non-medical people and the paramedical people, if they can get these children to us at an early stage, we can do a lot for them. And to assess the functional vision in children with visual disability and have a network of vision professionals to provide assessment and early intervention and rehabilitation. So the take-home message is a detailed ocular examination in children with developmental disability is mandatory. Visual problem can be treated early for prevention of visual disabilities and better outcome. So I would conclude saying that we have to catch them young and catch them early and do whatever best we can do for them. Thank you for your attention.
Thank you, Dr. Chaudhary. It's a really very major problem, especially in CP children. So thanks for giving a nice picture of the problem. Thank you very much.
Thank you, sir.
So, thank you, Presidium. Because time is very short, we have 10 more speakers in the next session. So we will have to go only 3 minutes by title. So in the meantime, just to switch over to second session, we have got a very brief program. Here is Dr. Kirandeep Kaur from Pondicherry, from Arvind Eye Hospital, Pondicherry, a fellow who has been selected for the honor of Acoin Secretary's Appreciation Plaque during the last annual conference of Acoin in Kolkata. But that time she couldn't attend. I'd like to request Professor Tariq Qureshi sir, the Principal, Anantnag Medical College and President of Association of Community Ophthalmologists of India, to honor Dr. Kirandeep Kaur here with the plaque and the Uttariyo.
So second group will come now.
Many people are not there.
Thank you, sir. Professor Arvind Tenagi is here from Belgavi Medical College. Dr. Prerna Upadhyay from Bhopal. No. Now I would like to request Professor Indermohan Rustogi and Professor Purvi Bhagat to join with the Presidium on the dais and to start the second session. I'd like to request the Acoin Secretariat staff to arrange for the chairs for Professor Purvi Bhagat and Professor Indermohan Rustogi. And please be there, sir. बैठ के रहो, आप बैठ के रहो. No, सब बैठो ना. It's community. It's community. So, now I would like to request Professor Indermohan Rustogi to go on with the second session, to call upon the speakers of the second session.
Should I call the speaker? So I request Dr. Subhadra Jalali. Dr. Subhadra Jalali.
She was here.
She is not here. Okay. Dr. Lakesh Madaria. Yeah. Yeah, people are not here actually. Dr. J.P. Mishri Kokar. Madaria sir is there. Okay, yeah, sir. Dr. Madaria will talk about epidemiology of diabetes and incidences of diabetic retinopathy in India.
Yeah.
Dr. Madaria.
Respected chairperson, our dynamic president, Acoin national president, Professor Tariq Qureshi sir, Professor Vasisht, Nepalia sir, and the person sitting in the dais and off the dais. As we all know, the diabetes in India has become our country has become the diabetic capital. And the way we are facing the problem every day. Next. Yeah. Epidemiology, diabetes and the incidences of the diabetic retinopathy. Understanding the diabetic retinopathy, as we all know, it is a chronic disorder characterized by persistent hyperglycemia presenting with the various manifestations. The epidemiology of diabetic, if we see in 2020, it was 473 million in the world, and by the 2030, it is going to be projected to 643 millions, and by 2040, 783 millions. This is the scenario in the world level. If we think in our country, by 2020, it was 77 million. Every one person from 11 Indian is suffering from the diabetes. And it is second most detected in the world after China. And by the 2030, the diabetic patient will increase almost up to the 100 million. So according to the International Federation of Diabetes, it is expected about 130 million by 2030. India has become the world capital and it will remain for 30 years. It is a very shameful for us. This is the figure shown in the world level all over. In 2015 it was 415 million, and by the 2045 it is going to be projected to be 783 million. So according to the International Diabetic Federation, this is the figure of Europe and the Middle East and Africa. Everybody is facing the same problem. It is increasing like anything. According to the International Diabetic Federation, this is the different figure as just we have discussed. National Diabetic and Diabetic Retinopathy Survey. The prevalence was found 11.8% over age of 50 years and prevalence was found 6.5% below the age of 50 years. Prevalence of diabetic retinopathy, 16.9% of diabetic population above the age of 50 years, 18.6% at the age of between 60 to 69 years, and 18.3% by 70 to 79 years, and the same 18.4% above the 80 years. So higher prevalence of diabetic is reported in Tamil Nadu and Kerala state. 50% of all diabetic patients live in the maximum, the first in the world is the China, 98.4 million, in India it is 77 million, and in USA it is 20.4 million. This is the figure shown as one adult out of the 100. The more worst position is that in every 6 seconds, one person is dying because of the diabetes. So this shows how severe it is. Day by day it is increasing. The incidence of diabetes in India, the India urban population is having more diabetes due to lack of exercises and the genetic determination. Morbidity increases due to low level of education and poor awareness. The dangerous pre-diabetic zone, this is a very important thing, we have to think over it. 1 in 6 Indians are pre-diabetic. 14% is the prevalence rate who have been tested. Patients having fasting blood sugar more than 126 milligram, diabetic patients as 77 millions, pre-diabetic is almost 14% of the total population. So the diabetic awareness program is very important. We have started in our Chhattisgarh along with the association of the IMA. I was the president of IMA also. We always organize camp along with the physician associations and we educate the patients, because if this pre-diabetic patient will not be properly educated, then it will be turned to be diabetic, which will be a very, very dangerous position. Very poor awareness. 25% of urban population is not awareness of the diabetic problems. The 12% of diabetic patients are aware about its complication. 40% of diabetic patients were aware of its causes of damage taking place in the different systems. WHO divided diabetes, as we all know. The prevalence of diabetes 0.5 to 28% in different places of India. The risk factor of diabetic retinopathy, diabetes is leading cause of blindness in Western Europe. Relationship of diabetic retinopathy with this HbA1c. So, in short, we should control the diabetes at all, in all respects. This is the different duration of diabetes related with the development of the diabetic retinopathy. Due to shortage of time, I am just going duration. I will not going into detail. This is the different proliferative diabetic retinopathy, and this is the different incidences of retinopathy. Please conclude, sir. Sir. So, the take-home message is that we should have a very good diabetic control, number one, and awareness regarding the diabetic retinopathy is a must. With this, I again thanks to everyone. Thank you very much.
Thank you, sir. In fact, we conducted National Diabetic Retinopathy Survey, and as far as the prevalence of diabetes 12% and DR 16.9%, this figure out there, but probably the most important finding was that 90% people, they have never got their eye examined, 90% of diabetic patients. This is the level of awareness in our country.
Thank you, Professor Prabin Vasist. In the meantime, I would like to request Dr. Chilkuri Sharad Babu from Telangana to take the chair in the Presidium. Dr. Parikshit Gogate sir, please do take the chair. Professor Rajesh Joshi, please take the chair in the Presidium. And a community program. I would like to request Professor Arvind Tenagi, Professor HOD, Belgavi Medical College, to be felicitated and honored by Professor Tarek Qureshi, our President, sir. Professor Tarek Qureshi, sir.
Sir,
yeah, please do come. With the felicitation. Professor Tarek. Professor Arvind Tenagi was awarded with President's Appreciation Gold Plaque during our last annual conference in Kolkata held in August 2021. He couldn't attend there. Now it's our golden opportunity to hand over the award to him by the golden hand of our President, Professor Tarek Qureshi sir. Professor Arvind Tenagi from Belgavi Medical College, Karnataka. Thank you.
Now I request our next speaker, Dr. J.P. Mishri-Kotkar, to talk about economical pterygium surgery.
It's a humble request to each one of you, please go on with title slide only, because everybody would be given only 3 minutes, and after that I would request the Presidium to stop, otherwise everybody will not get the scope.
3 minutes.
Thank you very much.
Good morning everyone. I am going to present economical pterygium surgery, a very short presentation. Pterygium, all of us know, is a trivial condition in India. And why I chose this topic here was this patient, this young guy, 22-year-old labor, very poor, came to us with double-headed pterygium in both eyes. So he was very poor, not affording. He had gone to some private institutions and was told a hefty amount. So that time only this opportunity came, so I said I will include this. And how do we go in community about these patients? So for pterygium, all of us know that operative is the choice, and our goal is to achieve a topographically smooth ocular surface with very low recurrence. Conjunctival autograft is the gold standard which everyone is practicing these days. This graft can be secured to the bedside or the scleral surface by sutures or fibrin glue or autologous blood. Sutures, time consuming, it induces irritation, redness, lacrimation, recurrence rate is very, very high, and possibility of granuloma and abscess is also there. So we do not perform this. Glue is a good option, but it is expensive and allergic reactions are possible. So for community purpose, this is also not a very good option. Autologous blood, which can be placed without any suture or glue, best is approach as it is natural, no extra cost, very low recurrence rate and excellent cosmesis. The only thing, you may be having problem initially, but once you learn the technique and the graft is secured for 24 to 48 hours, you get very good results. And the essential factor here is to obtain a thin graft. And the technique is just remove the graft from the, just remove the pterygium from the head and place it over the scleral bed. This is a very early post-op picture of a patient. One more picture of early post-op picture. This patient had a nasal as well as temporal pterygium done. Few more pictures of post-op pictures of the same technique. 4 week and 4 days post-op and 4 weeks post-op. And the patient which I was discussing initially, these are the post-op pictures. Both his nasal as well as temporal surgeries have been done. And the patient is very, very happy now, and we also are very satisfied to give him a very economical pterygium surgery, We do a lots of camps, and in our zone, lots of pterygium patients come. So even for camp patients, since the year 2014, my department has transformed to this. All my residents are also practicing this technique only. So I would conclude by saying that pterygium excision with conjunctival autograft without any glue or sutures is economical, very low recurrence rate, good cosmetic outcome, and can be practiced with minimal resources. Thank you for patient hearing.
Thank you so much, ma'am. And you nicely talked and finished in time also. Now I request Dr. Sanjay Kumar to talk about Tele-Ophthalmology, reaching the unreached rural villages. Dr. Sanjay.
By that time, we will request Madam Chandana Chakravarti, Madam, to have presentation ready. Yes, sir. Dr. Sanjay, sir.
My screen, I'm waiting. Good morning, everyone. My topic is Tele-Ophthalmology, reaching the unreached rural villages. Tele-Ophthalmology is a branch of telemedicine that delivers eye care through digital medical equipment, and synchronous Tele-Ophthalmology enables real-time interaction between participants. While 70% of the population of India lives in rural areas, over 70% of the doctors practice in urban areas. So Tele-Ophthalmology plays an important role in bridging this divide and reaching the remote areas. So West Bengal Tele-Ophthalmology project was carried out basically in 2 districts, Bankura and Paschim Mednipur. 10 centers were selected in Bankura and 10 centers were selected in Paschim Mednipur district. And then Bankura district health centers were connected with Bankura Medical College, and Paschim Mednipur district health centers were connected with Mednipur Medical College. So the training was done at RIO and Chaitanyapur. Vision centers were equipped with all the necessary equipments, and all the optometrists were given training for refraction and slit lamp examination and how to do teleconsultation with the medical colleges. So the population covered in which resides in these 2 districts is about 26 lakhs, and of these, during this 5-year period, about 232 patients were consulted during the in different health centers, and of these 40% required refraction and glasses, and only 6% were referred to medical colleges. So this is the data from different centers, and mainly the persons who were referred to medical colleges were basically because of cataract and retinal problems. The point to be noted over here is that even in this era we got some patients, about 66 patients with vitamin A deficiency. So Shankar Netralaya has this mobile van which does this Tele-Ophthalmology, and by their study they have shown that they conducted 6,500 camps and about 7 lakh patients benefited, and teleconsultation was done for 55,000 patients, and spectacles were issued in 25% patients. Arvind Tele-Ophthalmology Network has both vision centers and mobile vans, and through vision centers of 91 vision centers they covered a population of 85 lakhs, and 90% can be fully treated on site, only 10% referred to the base hospital. So the benefits include that we can reach the remote inaccessible areas, it saves time, money and effort of the patient. We can provide timely intervention in emergency situation. Most of the patients can be treated on site, avoids unnecessary referrals, and we can get expert opinion. A study revealed that 26% of the patients were living with potentially sight-threatening diseases without any access to specialized medical care. It can be used for screening for diabetic retinopathy, can be used for creating awareness for eye donation. The limitations include high cost of initial investment, last mile connectivity of internet, poor quality of images, non-availability of trained staff, policy barriers, medical legal issues, and regular updating of software and hardware. So to conclude, it's a cost-effective technology which provides high-quality eye care to people living in remote rural areas. 90% can be fully treated on site. Early and timely treatment prevents permanent visual complications, and due to less time and financial implications, there is improved compliance for follow-up. In the pre-corona area, it was a very simple and neglected branch, but after corona, it became the star. So I acknowledge all the people who have contributed to the West Bengal Tele-Ophthalmology project, all the staff of the IL and FS education, all the optometrists, all the staff of the Midnapur Medical College and Bankura Medical College, and all the staff of RIO Kolkata and Chaitanyapur who were involved in capacity building. Thank you.
Thank you, Dr. Sanjay. This is a need. Tele-ophthalmology really, it has become a need of the society to reach the unreached people. Thank you very much. Now I will request Madam Chandana Madam to deliver his lecture. Before that, the next speaker, Dr. Sarita Agrawal, Professor Panda. Please load. Yeah, Madam, please carry on.
A very good morning to all of you. Thanks a lot to Acoin Scientific Committee for giving me the opportunity to talk in this session. I'll be talking on orbital miosis, a very neglected disease almost in all the developing countries. Very little has been talked about this particular topic, I feel. The term miosis, as all of you know, it means fly. The fly, the Diptera or Orthopodia, from that the fly or the maggots, they are the culprit actually. It's a very rare condition, and the eye involvement in human miosis is very less, though it is less than 5%. Orbital miosis is a rare infestation of the orbit all over the world. More common, as you all of know, that this is more common in tropical and subtropical region. Why? Because of warm and humid climate, along with the lack of sanitation, poor general hygiene, poverty, these all lead to the growth of these flies. These are mainly associated with malignant tumors and trauma. Sometimes in immunocompromised patients, they are also susceptible to this. The management depends on the extent of involvement, ranging from the simple removal of this maggot to sometimes you have to go for a destructive surgery, like you have to sacrifice the globe and the sinuses also. The conventional management involves a manual removal, suffocating agents, anesthetic agents, ivermectin, the broad spectrum antiparasitic agents, and surgery. We did a retrospective study in our center to find out how common it is. We collected the clinical data of consecutive 8 patients who were treated at our center between 1 year. I'm not going to, I have 8 cases, but I will show only a few. This was a 40-year male. The patient gave history that actually the patient was drunken and he fell on the ground 4 days back. He was lying there only, and when the patient came to us, he had symptoms of severe lid edema, periocular edema, ulcer below, and we could not even examine whether the patient, the eye is intact or not. At this point of time, we started the management. Now, look at the patient. This maggot, they have a peculiar tendency, whenever the light is fallen on that, they will try to go away from their own side. And this was the final outcome. We treated the patient with, this is our common practice, hydrogen peroxide instillation, and that causes a destruction of already necrotic tissues and easy removal of the larvae. And then we do the debridement. This you have to continue for at least 7 days. And these 7 days, within 7 days, the patient will be fine and you will get a very nice maggot-free wound. And apart from that, dressing with the povidone iodine solution every day should be done. And intravenous broad-spectrum antibiotic, because many a time these are associated with secondary bacterial infection, which added the more devastating condition. These are some of my cases. Almost most of the cases, either squamous cell carcinoma, basal cell carcinoma. You can see the patient full of maggots. They have a tendency of the inflamed area surrounding the wound and the crawling sensation. And the patient, as they are very older age group mostly, so they cannot even say. This is how we instill the hydrogen peroxide solution drop by drop. These are some of my cases. In a case of retinoblastoma with fungating mass, multiple maggots, almost 200 maggots we had to clear within 1 week. But finally the girl became fine. is necrotic tissue, the same story you can see. And after treatment, this was a result of few of our cases. All the cases become maggot free, as I told, within 7 days. Sometimes you have to go up to exenteration or reconstruction with the musculopedical flap as an necessary. So
next
tropical and subtropical countries, eye malignancy, old age, usually unilateral. These already I talked about the turpentine oil, liquid, paraffin, petroleum, jelly, hydrogen peroxide, all these as
Madam, please
inside.
conclude.
Okay. So to conclude, these are common in cases, as I told. The only thing is that we should not neglect these old people, and we have to take care about this. You can easily avoid it. That is the thing. Thank you.
Thank you, madam. Thank you very much for a nice presentation.
Good morning, everybody. It is a pleasure to be here. Today I am going to present on investigational drug delivery technologies in glaucoma. The slide doesn't move. So, drug delivery to the anterior segment of the eye always has a challenging issue. Topical eye drops, the most common route of administration of treatment for ocular anterior segment disease, has a low level bioavailability of 1% to 10%. In addition, the topical eye drops often have a short duration of action, so that frequent application of drop is required, which may result in patients' discomfort due to ocular surface toxicity, and current dosage regimen is highly dependent on patients' compliance. Different drug delivery systems have been investigated to address these limitations related to eye drops. Now, coming to the investigational drug delivery technologies, sustained release bimetoprost loaded biodegradable implant, subconjunctival route like intimolol loaded microfilm drug delivery system, the Foresight Vision's Helios slow release insert, the punctal plug delivery system, the anterior segment sustained release therapies, and the intracameral polymer injections. Now, what are the constraints for ocular drug delivery? The constraints for ocular drug delivery application relates to the lower ocular bioavailability, the precorneal drug loss, rapid tearing, non-productive absorption, transient residence time, impermeability of the drugs to corneal epithelium, nasolacrimal drug drainage, and systemic toxicity of the drug. The strategies employed to increase ocular bioavailability include the design of the drug delivery devices to release drugs at control rates, the use of vehicles to retard the precorneal drug loss, and the synthesis of prodrugs with increased corneal penetration bioavailability. Now, not going into the details of the biodegradable implant, now coming to the individual ones, the sustained release prost loaded biodegradable implant. It is an implant which is administered intracamerally and involves the use of biodegradable solid polymer drug delivery system for slow sustained drug release. Now, coming to the anterior segment sustained release, the OXDTI is designed as a bioresorbable intracameral implant. Next, coming to the polymeric film, the timolol loaded PLGA, which is the polylactide glycoside films, are investigated for long-term drug delivery. Punctal plugs, we all know, we use it in our routine practice. Now, the Foresight Vision Helios, the Helios drug-eluting drug developed to lower the intraocular pressure in glaucoma patients by about 20% after 6 months. Hence, to conclude, the development of sustainable drug delivery system has been widely explored through the years in the last decade, and further studies are needed for meeting the potential challenges in the area of ophthalmic therapeutics to overcome the limitations of conventional formulations like low bioavailability, frequent drug dosing interval, systemic toxicity, and patient compliance. Thank you so much for your patient hearing. Thank you.
Thank you, madam. Thank you. We are running really very shortage of time. I will request Dr. Sudipto Ghosh to deliver his topic.
I was Sudipta.
Yeah, sorry. Professor Panda.
Very good morning to all. Thank you so much, Dr. Swapan Samant sir and Team Acoin, for giving me this opportunity. My topic for presentation is ocular manifestations in HIV positive cases. It's a study. Human immunodeficiency virus is a lentivirus, as everybody knows. It's a member of the retrovirus family, and it has threatening opportunistic infections and malignancies. Ocular lesion in the anterior segment of the eye may include blepharitis, dry eye, herpes zoster ophthalmicus, uveitis, keratitis, molluscum contagiosum, squamous cell carcinoma, and Kaposi's sarcoma. Ocular lesion in the posterior segment of the eye includes retinal vasculopathy, unusual malignancies, neuro-ophthalmic lesions, and opportunistic infections like CMV retinitis, toxoplasma choroiditis, syphilitic retinitis, etc. Our work aims at a comprehensive study of the incidence and various ocular manifestations in HIV positive cases. The study was conducted in our college for a period of 2 years. The proved HIV cases attending the ophthalmology department with ocular problems were studied. The HIV positive cases referred from other departments like medicine, surgery, pediatrics, pulmonary medicine, obstetric gynecology, and HIV positive cases attending ART center were also taken into consideration. Now, out of the total 211 patients, number of cases with ocular manifestations were 61. So the percentage is 27% of the cases had ocular manifestations, and of different age distributions, the maximum patients were found in 31 to 40 years of age, that is 47% of the cases, and 21 to 30 years of age had also 13%, that is 21% of the cases. And more number of cases were male, 45 cases were male and 16 cases were female. And regarding the socioeconomic status, the low socioeconomic status in 40 cases, and it's also 12 cases in high socioeconomic status. Mode of transmission, mostly sexual transmission, then blood transfusion and drug abuse. Percentage of complaints in HIV positive cases, the ocular complaints are redness, pain, photophobia, and growth and defective vision. Incidence of ocular manifestations, ocular adnexal, anterior segment and posterior segment diseases are found. Herpes zoster, blepharitis, molluscum contagiosum, and bacterial conjunctivitis, dry eye, viral keratitis, anterior uveitis, and Kaposi's sarcoma. 63% of the cases had bilateral presentation and 36% of the cases had unilateral presentation. This is one of the case of herpes zoster ophthalmicus in HIV positive case. This is a case of molluscum contagiosum. And to conclude, the incidence of ocular manifestation was found to be 27%, which is at par with the other studies, and more common ocular manifestations were posterior segment of the eye followed by anterior segment. All the HIV positive patients should be screened for any ocular involvement, as they may be asymptomatic but may have a posterior segment pathology which is not diagnosed at an early stage but can lead to some blinding disease. HIV is a deadly disease taking toll of the life if untreated, and most of the patients present with ocular manifestations at some point of the disease process when the CD4 cell count gradually declines below a critical. So, early diagnosis and starting of antiretroviral treatment can maintain the CD4 concentration, decrease the viral load, and prevent various ocular manifestations. Thank you.
Thank you, madam. Thank you. Our next speaker is Pragya Ahuja, madam.
Good morning, respected teachers and esteemed faculty. I'm going to be talking about myopic Phobias crisis, a complication of pathological myopia. What exactly is pathological myopia? It is a globe elongation and refractive error of at least -6 diopters or an axial length elongation of more than 26.5 millimeters, which is associated with degenerative changes at the posterior pole. It has a variable prevalence in various studies from 1 to 4%. It includes diffuse or patchy chorioretinal atrophy, posterior staphyloma, lacquer cracks, fuchs spots, CNVM, and retinoschisis. These are the various findings that are seen with pathological myopia: the tessellated fundus, the lacquer cracks, the chorioretinal atrophy, fuchs spots, CNVM, the retinoschisis, and the posterior staphyloma. Pathological myopia has earlier classification was the meta-analysis for pathological myopia, which grades from category 0 to category 4 based on the macular involvement. Category 0 has no macular lesions, 1 has a tessellated fundus, 2 has diffuse atrophy, chorioretinal atrophy, category 3 has patchy atrophy, category 2 has patchy atrophy, category 3 has diffuse atrophy, and category 4 has macular atrophy.
Along with this, plus signs were included in this classification, which included lacquer cracks, myopic CNVM, and fugue spots. However, this classification was not useful for classifying pathological myopia, especially for the macular changes, for which the ATN classification was adopted, which included A for atrophic, T tractional, and N neovascular component.
Madam, please highlight the conclusion of the presentation.
Yes, sir.
We are falling very short of time.
Yes, sir. Yes. So it is basically a myopic traction maculopathy, which includes foveal cyst, retinal thickening. It can be associated with the lamellar or full thickness lamellar hole with foveal detachment. The pathogenesis is that it is an imbalance between the inner and outer tangential forces, which causes a split in the retina. There was a patient who came to our OPD in 2019 with complaint of heaviness in both eyes, right more than left. She had childhood amblyopia in right eye with a vision of 1/60. She had early cataract in both eyes, for which she was advised surgery, and in left eye on fundus examination myopic maculopathy was seen with partial PVD vitreomacular traction. She was advised surgery, but she was lost to follow up. This was the fundus image available for the left eye at that time. Right eye images are not available. The OCT showed VMT in the left eye. When she presented to us again in 2002 in a retina clinic for further follow-up.
Please conclude.
So basically, I want to stress the fact that even that pathological myopia patients have to be screened in time, and it is very usually ignored in our OPD clinics that we send these patients away without proper fundus screening. And it is important to help prognosticate these patients as well and to keep them in close follow-ups, whatever we can help them.
Thank you.
So you can finish in 1 minute. We are giving.
Yes, sir. I think I'll make the crux. So good morning, everyone. To respect the time of the next session, I'll just go through. I'll just give the sensitizer that primary eye care is not like the conventional eye care, the conventional eye camps right now. There are two things which drive the future of community ophthalmology and primary eye care. These are the new portable equipments and the data management system. In the new equipments, we have portable slit lamps, we have portable autorefractometer, portable NCT, visual field analyzer, fundus camera. So all the posterior segment and the anterior segments, we can use these diagnostic modalities in a portable thing, and we are using these all at our RP Center Community Ophthalmology Department. The other important thing is just a sensitizer for all of the residents, especially or those who want to make their data management in primary eye care paperless. This is the Open Data Kit application. It's a mobile based application. In fact, all the surveys which have been conducted under Dr. Vashisht in RP Center AIMS, which may be rapid assessment of assistive technology or RAP surveys or RAVI surveys in Gurgaon, we are using this Open Data Kit app. This is freely available. These are online forms. I'll just quickly go through that. In our department, the daily report of the primary eye care centers, the diabetic retinopathy details, the health education events with their topics, the reach-in program details, that how many cataract patients were referred, how many of them were operated, and how many of them are in the waiting list. Everything has been maintained in the paperless form in the ODK app. And the AI and Tele ophthalmology has already been covered, and this is not something which is very much philosophical. This is evidence based that use of technology enables the delivery of low cost and quality eye care at doorstep.
Please try to conclude.
Yeah, and RP Center in community ophthalmology, we are practicing that. Thank you so much.
Thank you.
Yeah, so I'm during the pandemic actually for ROP we did some new things, and now it has become the new normal for these patients, and it was the Indian ROP Society which immediately as soon as the pandemic started, we said that should we be doing ROP screening, should we be going out, what are the protocols? We fixed up new protocols which had the safety for patients and parents, and we said that yes, ROP is an emergency disease, we are not going to stop it even when there is complete lockdown. So we just changed certain things, like we started teleconsult, we started reducing the follow-ups by various strategies, and we divided the babies into high risk, low risk, and those who were low risk were called for later follow-up than usual, and those who were high risk were immediately treated even if they were at borderline of treatment. And so what I want to highlight is that the main thing we did was that we provided full care for these patients, and during the strict lockdown of the first 69 days, when everybody was closed and all services were closed, we still saw 200 babies at that time, out of which more than 75% were in the outreach, means in the different districts and different hospitals.
Please conclude,
so we
madam.
took special permission to go there, and currently now the same protocols we are now following, because that has reduced our follow-ups and the efficacy is same. So we hope that this paper will come out and then you can read all the details.
Thank you, Madam Jalali, Madam. As we are having a... Thank you very much.